So these are really important clinical studies. The whole concept behind this is that a lot of patients are on oral anticoagulation for a variety of purposes, and they have devices implanted either initially or have generator replacements and are on anticoagulants. So what do you do with anticoagulants? So the first BRUISE study, BRUISE CONTROL 1, looked at patients who were on warfarin and compared randomized patients to uninterrupted anticoagulation with warfarin versus bridging with heparin. And that study clearly demonstrated that there was a much higher risk of being on intravenous heparin and really has changed clinical practice. So that study was previously published. The next study, because there are probably about 2/3 of patients on anticoagulants, are now on the direct oral anticoagulant therapy agents and instead of warfarin. So they took it a step further and compared uninterrupted anticoagulation with a direct oral anticoagulant compared to holding the drug for at least 24 hours prior to the procedure, and really showed, actually it was stopped on the second interim analysis, and the reason for that is that it was futility because both groups were similar. It was 2.1% risk of these clinically significant hematomas. Then what the investigators did is combine the data from the two studies and looked at other factors that might influence bleeding risk. And what they found is that, really importantly, that the use of other antiplatelet agents can increase the risk of clinically relevant hematoma. And the relevance of that is that hematomas can lead to an increased risk of infection. So the bottom line, the take-home message is that we should really be looking at those patients and looking at the antiplatelet drugs and determining whether or not these are essential drugs. Some patients are actually even on 2 different antiplatelet drugs. Might that even be worse than a single drug? So I think future analysis will need to look at whether or not specific antiplatelet agents are things like Plavix worse than aspirin or not. We don't have that information yet. Being on 2 different antiplatelets, is that worse than being on one? You know, we think so, but this study wasn't powered for that. There were only 25 patients who were actually on 2 different antiplatelet agents. Highlights from the Congress, I think that there really have been some really important late-breaking trials. I think looking at the anticoagulation concepts, there was another trial looking at apixaban and whether or not we can use the direct oral anticoagulants and continue them at the time of atrial fibrillation ablation, and looking at safety and efficacy of that. And that also shows that we can use these drugs. We don't need to interrupt them. We don't have to take the risk of thrombosis at some of these procedures, whether it be device implantation or whether it be ablation. So I think that's really important.